Welcome to our listeners. We've got another episode of the 20-Minute Clinic. So good to be back. My name's Amit Paik, GP in Carlisle, and very much host for this podcast along my other colleagues. And across to my right.
Hello. I just do the wires, do the technical things, keep him on track. Yeah, I work in comms. My name's Paul. There you go. I've got to say who I was,
Look, and I have to say, I am really pleased we've managed to encourage her, and it's taken weeks to try and encourage.
Have you been coaxing?
Coaxing away, working away. It's happened, and she's here, headphones on, microphone present. I am here today with Karen Little. Karen is our esteemed pharmacist over at the surgery. I'm so glad she's been able to come on because I really want to make sure we absolutely represent the diverse array of professionals we've got in primary care and pharmacists. Having worked with them over the last few years at the surgery and beyond, I think they do a fantastic job, and I'm really keen to hear Karen's story. Welcome, Karen.
Hi, Amit. Thank you very much for having me.
Right, it's okay. Come on.
He does a good build-up, doesn't he?
He does a good build-up.
I'm really keen to, because we spoke a lot about this. I think we've had those kind of meetings. We've kind of sat around and talked about the role of the pharmacist, how far it's come along. I'm just amazed that we can get some of this down in a recording somewhere just for other people to hear. Let's start with, what's your journey been?
Okay, well, we'll start the journey 35 years ago.
Just 35?
Only 35 years ago.
Me. Go on.
In the 80s, obviously at the University of Manchester. Qualified as a pharmacist in 1990. Mm-hmm. Worked in community pharmacy for 25 years.
Wow.
And then decided that I wanted to have a change in career path. And that was in 2015 when these jobs in the GP surgery were becoming more available.
Okay.
And I was really in the surgery just before that happened. And then I was on the pilot training pathway, the GP pharmacist training pathway. I was on the pilot one, so the very first one.
Wow.
And we've gone on from there. Within that role, I've developed over the years. I've done a lot of anticoagulation and osteoporosis, sort of leading as such in the surgery and becoming quite well knowledged with those subjects.
Are they specialist things then within pharmacy?
Not within pharmacy,
No.
within GP surgery.
Okay.
It's quite a specialist thing, and I think the GPs like us to have
Fantastic.
that role.
Yeah.
I think osteoporosis can be quite a time-consuming, which is very difficult for a GP to do in a 5-minute appointment slot. So having a pharmacist to do it perhaps works better for the whole team. And that just brings me on to working as part of a team, because we're all very different in the GP surgery, and Amit will agree with me here.
Love the diversity. Just it's fantastic personalities.
Do not ask a pharmacist to do anything quickly. And Amit is laughing now because he knows.
Is this inside medical joke things?
I have to say, I for the record, because I feel as though we're going to get backlash otherwise, I love working with our pharmacy colleagues. I think they're incredibly thorough and really do an amazing job to support us, I think. But you're right, actually, and that quality of being very in-depth and ensuring standards remain high throughout careers and through the work here it's why they're perfectly placed here, I think.
I would agree, and I feel my place here is to be very thorough, to support the GPs, so the GPs know if we've been involved in anything, they can rest assured and know that we have looked into everything for them. Any medication requests from the hospital, interactions with other medicines, you can rest assured knowing that we've looked into it, but that doesn't take 2 minutes. It's more like 2 hours. No.
Well, steady on, Karen, steady on. So, look, there's a huge amount to unpack there. Absolutely fantastic. We can go into the depths of the qualities and how pharmacists add towards primary care. Let me just go back. What was the point about that transition from community pharmacy into practice-based? What made you make the jump?
So I think after 25 years in the community pharmacy, I'd always been more clinically minded than management as such, and it was a combination of both in the community pharmacy And I wanted to extend my knowledge in clinical areas rather than management area. So that was a big push. I wanted to do my prescribing, so that was another big push. And I just like working as part of the bigger team. Obviously, I had a team in the community pharmacy, but I like working, as we've just said already, I like working with the doctors, the nurses, the physiotherapists, the paramedics. It's nice to work as part of a bigger team, but really to extend my clinical knowledge. And I'll be the first to say, when I first came from community pharmacy, you think you know a lot. You don't actually, you don't, there's a massive amount of work that has to be done to get your competencies up. You can't just transition without doing lots of work to do that. And I think anybody who thinks, oh, community pharmacy is awful, I want to go into a GP surgery, it's going to be easier, is absolutely wrong.
Wow, yeah.
There's a lot of work that has to be done to get yourself to the standard that's required. And I always say to people, you can't know everything, but you have to know where to look. And that's
true.
the key.
Yeah,
that's the
absolutely.
key. It's knowing, having a set of sort of guidelines. Pharmacists love guidelines, by the way. It's our favourite thing.
It's your thing,
Love
isn't
a
it?
It's a favourite thing, a guideline.
thought,
We
wow.
love it. We love it. Doctors and nurses don't love them as much as
Well, I
pharmacists
think-
do.
Actually, thinking about the pharmacist, I know this pans out. Yeah, they do love a guideline.
We love a guideline.
Yeah.
It's knowing where to look, though. It's
Yeah,
knowing where
okay.
to look to get the correct evidence-based advice, because you can't know everything. So
It's look, so true. What was life back at 2015 when you moved into primary care? So before sort of 2020, when the R's rolled, the wider opportunities for increasing allied healthcare professionals into primary care.
Yeah.
What was that time like for a pharmacist?
Yeah, so it was a new time. It was new. I mean, the day that I started working in the GP surgery was the day I started the prescribing course. For the first 4 months of my new job was very, very involved with doing the prescribing course. So there was a lot of study work as well as learning in the surgery. And I had a very good GP mentor who I obviously sat in with a lot. And it was all about I did a lot of work in my own time. I wanted to get my competencies up. The surgeries at that time had specific things they wanted us to do. So anticoagulation was a big thing that I was asked to do. And then osteoporosis, again, was another big chunk of work I was asked to do, as well as the medication reconciliations and discharge summaries. They were big pieces of work.
Huge amounts of work, really, isn't it?
Huge amount of
And
work.
I can imagine that gradually grew and grew and grew.
Yeah.
Just because as practices got used to almost having you there. I know when I was a registrar over at Brunswick, I came across you a few times, didn't I? When I was in training down there, it was fantastic to know that was an additional resource to go to.
Yeah.
What's changed, do you think, since the R's roles have come online and pharmacists have increased in numbers into general practice?
Yeah.
How has the role changed?
I think probably hasn't changed a lot for us here, because I think our surgery is always very much valued pharmacists, which has been really nice. We've always been very valued, although we can be a bit of a dumping ground for things. We can be a bit of a dumping
Goodness
ground.
me,
Just
Karen.
pop that to the pharmacist.
I thought we were going to keep this PC. What's happened here?
I had to get that in. I
This
had
is
to get
headline in this.
I had to get in the dumping ground.
I
of the
would
pharmacist.
rephrase that from dumping ground to fountain of all knowledge.
Okay, that sounds much better than dumping ground.
Well
I
reframed.
agree.
Well
I agree.
reframed, yeah.
So for us here, I don't think the amount of work we're doing now is, for me, it's better. It's become more varied, the amount of work. So before 2020, it was very much anticoagulation, INR clinics, osteoporosis, trying to fit in other things in between. Now we're more structured. We have more to do, but it's in a more structured way, and it's more variable. So I'm not doing osteoporosis half a week and anticoagulation the other half of the week. It's just part of the week, and it's better because that's why I like GP practice, because of the variability.
Yeah.
And, if you want to be a specialist osteoporosis pharmacist, then go and work as a specialist osteoporosis pharmacist, where you're doing that all the time. But I like the variability, the generalism.
Excellent.
Yeah.
And from speaking to colleagues, across the region and beyond, what's the feeling from their point of view? How has it changed over the last few years, you think?
So there's a lot more there was a mass exodus really from community pharmacy into GP practice. I think with the
really?
funding,
Okay.
as you said, from 2020, there's been quite a big move from community pharmacy to GP surgery. I think some of the other people that I speak to perhaps have a more simplistic role in a way to what we do here. I think we do some perhaps more complicated things, but that's perhaps due to the experience that we have. We are able to do those more complicated things.
Okay.
We're not just, some pharmacists work in GP surgeries that just do medication reviews.
Yeah.
That's all they do, or meds reconciliation. Yeah. They don't do any of the anticoagulation, osteoporosis. And it's more simplistic, I think, is the best way of putting it.
Yeah. Okay. I mean, I suppose, from my experience, there's huge opportunities there, isn't there, really, with pharmacists into primary care. Just thinking beyond then, I think general practice, we know this, Paul. I mean, how many times we spoke about this? We're on a knife edge when it comes to resources and demands at the moment. And we were often looking around for the next big thing to help us smooth things along. But we often forget actually there's a huge amount of resources we've already got in practice. What do you think? Do you think our pharmacists, not just here, but also across the region and wider, do you think we could be tapping into them in a different way or utilising their resources to help with that onslaught of demand?
Yeah, I do. And I do think that we are actually a really good model here in our surgery. And I think that other surgeries would, they would probably value seeing how we do things here, because I feel we do, I hope you'd agree, Amit, that we do help a lot in the surgery team, and we take work off the GPs, which is the whole point of this, is to be able to help. We look at things differently, and I think that's important. Different health care professionals will look at a patient's record in a different way. A doctor will look at it, a nurse will look at it, we will look at it. We are always looking at it from a medication perspective. We will see things that the nurses and the doctors don't see, as they will see things we don't see. And I think the combination of all of that together and looking at the patient as a whole is just really important part of general practice. And I do think we've got a really good model here. Having spoken to other pharmacists in other surgeries, I think we do a good.
I think I'm trying to be unbiased here, just so it's clear as well.
Well, I'm being very biased. But
that's the balance. We've got the biased and the non-biased.
I feel very biased.
What is it? I mean, because you said to me we're a good model here. What specifically do you feel that we do really well?
I think
I'll be interested to hear this myself. Go on.
Yes, I think that we have a fantastic team lead who organises us really well. She organises our workload and makes it achievable. It's more interesting because it's variable, and I think having that support from a supportive team lead is really helpful.
Are you going to name drop?
She also produces this with her other
she's
hand.
She's executive producer, absolutely.
Yeah.
So
multi-skilled.
Yeah. So I think having
shout out to Susie.
Shout out to Susie. Yeah. So I think having that organisation, because there is we know what primary care is like. GP practice, very, very busy, and if it's just a bit more organised, that is really helpful, because I think pharmacists tend to like to be very organised. It's part of the personality trait, if you like. We like to be organised. We need to have time sometimes to delve deep into things and look into things. And again, the variability for me is a big thing, because not doing the same old all the time.
So, all right, devil's advocate for a second, and this may well kind of go badly wrong. So, Paul, hold on tight for us this bit.
He likes controversy.
I've got to add it. So, look, I mean, so there's lots of diversity of roles into primary care, and we love them. Let's just, for the record, we absolutely love them. I think they're fantastic. They're keeping us afloat. So you cannot knock them at all. But the question I've got then is, you talked about the in-depthness, the time, the need to do a deep dive. How would you respond to the challenge of that we haven't got time for that in primary care? It's go. We just haven't got time or capacity for our pharmacists to do deep dives in the individual patients. What your response to that?
I think I would say that sometimes we need to do that, and that's why you're employing us. You need
She's
us.
good. She's very good, isn't
You
she?
need
Right, that was
us.
good. That was
You
good.
need us to do that. We're not the same as doctors and nurses, and you need us to do that so that the patient, we can guarantee the patient's safety and safe prescribing. But I do think we have to get the balance. You've got to get the balance right. You know, you can't deep dive into everything. We would never get anything done, but you've got to know what needs to be deep dived in and what doesn't. And I think that.
Okay,
But I
that's a
do
skill.
think we have to be allowed to do it because that's what we're here for.
Yeah, no, fair play. Because actually, there's a huge safety element of it as well, and it's been talked about already, hasn't it? Really, nationally, there's been a recognition that hospitals, if I'm really honest, you do a great job of picking up errors, and in primary care, for one reason or the other, which we could dive into another time, that we just don't do as a good a job of picking up those errors that we see. So we know they occur, arguably. So knowing our pharmacists is there to be able to do some of that deep diving and pick up the errors, provide a bit more safer cover. I think absolutely, definitely a role there, isn't there?
And knowing you're aware of that balance as well.
Yeah,
Of-
that's really
of finding
important.
that,
Yeah,
yeah.
Which is a skill that's quite hard because actually you don't learn that in the community, I'm guessing. That's
No.
something you have to learn
No.
on the job in
No.
primary care.
You do. You do.
What do you think then? Just pivoting, here you go, as a pivot. What's the future? Where are we going with pharmacists? Where are we going with the relationship between pharmacist and primary care?
I think that there's certainly a role, as we are doing here in this GP surgery. I'm not sure whether some other, and this is maybe a bit controversial now, I'm not sure whether
Here we go.
some other roles that are available are more technician roles
Okay.
rather than pharmacist roles. I think there has to be a distinct difference between
Yeah.
a technician's role and a pharmacist's
Because they've
role.
got strengths,
and
haven't they? They've
absolutely
equally
they
got strengths.
have. That absolutely they have, yeah. And I think that a technician's role is more of a robotic role, whereas a pharmacist's role is the opposite to robotic. You've got to look at the full picture of what's going on, not just concentrate. For example, if you've got a letter from a consultant saying start this medication. Well, you have to look at the full and think, is it safe to start this medication? The consultants don't always know the full picture, whereas to me, general practice pulls everything together from all the specialities, and they might not know about something that we do. And, you know, I've had it before where I have written back to the consultant and said, I'm sorry, we can't start this because of this. And the consultant's really happy with that because they didn't know that other piece of information. So we are pulling together information because we are the people that look after that patient, and then the specialities come into that as well. I don't know, would you agree with
I
that?
think there's
Amit?
something definitely there about diversification. So
Yeah.
embracing some of this medicine management roles. I think
Yeah.
technicians, you're right. I think they do a great job and they absolutely have strengths to be
Yeah.
able to get through some of the workload in a much more protocolized manner.
Yeah,
Yeah,
especially in medicines management. I think that technicians have got a bigger role to play in medicines management, and pharmacists have a bigger role to play in a clinical way.
Is that you talking out of a job?
No, because I do the clinical way.
So, no,
Not the
absolutely.
meds management, I do the clinical
Absolutely,
way.
yeah.
Yeah.
So, and yeah, you're right. So from the pharmacist point of view, it's very much a clinical angle
Yes.
of it all. Yeah, no, I can completely appreciate that. And you're right. As demand grows, there's a need to make sure that there's another member of the team to kind of support some of that medicine management, some of the clinical elements and safety. That's
Yeah.
a huge part of this. Yeah.
Yeah.
Particularly where there's kind of an emerging recognition that safety in general practice is of real importance.
Yeah. Yeah.
Really hard to discuss, isn't it, at a time when we're so busy and so maxed out? But I think it's something in that, definitely. Look, I mean, Karen, what can I say? Having you on has been really, really helpful. It's kind of almost encompasses a lot of our discussions to see if there is anything we can kind of talk about and celebrate. What would your final thoughts be for any budding community pharmacist, or even we've got a pharmacist student thinking, oh, primary care might be a place I want to go? What advice would you give them?
I would always say, coming from community, be prepared for how much you don't know.
Yeah.
So come in, be prepared to work hard. You need to get your competencies up. You need to be aware of what's going on elsewhere in the country, guidelines, national, local, know where to go. As I said earlier, you can't know everything. Don't even try and know everything, but do know where to go.
Okay.
That's what I always say. Do know where to go.
Paul, I don't know about you, mate. It's been really helpful.
It has indeed, and I have a feeling you're going to ask that big question, aren't you, that you
Go
ask
on.
everyone.
Absolutely. I hope this is kind of
He
carrying
likes
on.
to ask this big question. I probably get it wrong, but it's around if you could get
on.
anything to help you in pharmacy.
No, come on.
That's the
We got
question,
this.
isn't
All right,
it?
I'll say
You
it
do
again. I'll say
You
it
do
again.
He loves this question.
So look, I mean, I'm asking everyone, and Christmas special. Here we go.
Christmas special. He's obsessed with this
What
idea.
would be, if you could, what would be one thing that you would change for you to be a better clinician?
You're going to love it, Amit.
This is gonna backfire on me, isn't it? Come on,
It's going to backfire big time.
go on.
More time.
Oh my God.
Because of the way that pharmacists work. Everything's very pressured.
Yeah.
We'd always like more
It's
time
a
to do
hard
what we
balance.
have to do. Yeah.
It's a hard balance, isn't it? Really. Look, we'll take that away. At least you didn't say more money,
That's what most of you guys say.
Most people go, yeah, just hand us a wad of cash and we'll try and make things
Oh,
fix.
God, why didn't I say that?
Too late now. That's it. It's recorded.
That was
Sorry.
stupid.
No. Look, you know what? I think it's a really nice reflection, recognising some of the challenges about having pharmacists in practice, but the realism of having you guys here and actually the huge benefit you can provide. I've seen it myself. I've seen the huge amount of work that our pharmacist colleagues get through, and the number of times I get a task or a phone call or even a meeting where we've got an array of errors or near misses that we've discovered on the back of having you guys on board. So I think absolutely, I've said before, I'll say it again, very much integral to what is a developing, growing primary care. Karen, look, you know what, it's been really nice having you on and to be able to talk about your reflections, your thoughts as an experienced pharmacist in primary care. Really hope that helps any budding primary care pharmacist students to think about primary care as destination for careers.
A lot of scope by the sounds of it.
Absolutely, huge amounts, isn't it? And I love the fact that, yes, very much a generalistic approach. That can make the day really interesting. We both know that.
Yeah.
How many meetings we sat with and the day is quite interesting.
Yeah, it is.
Absolutely.
It is.
And I can't leave the podcast without saying, Karen, as well as being our value pharmacist at the surgery, resident Ibiza holiday goer. And she keeps saying to us it's from the old town. I don't believe her, still don't. I keep seeing his glow sticks in a drawer, so I think that's it.
I knew you'd have to get it in.
We've got to get it in.
You know,
I know, absolutely. Look, Karen, pleasure as always. Thank you so much for having us.
Thank you.
Thanks now.